Good morning, everybody. Can you hear me? Can someone give me a thumbs up? All right, cool. Thank you. Good morning and welcome. We have a little bit of a new format today, and I just wanted to explain to you some of the rounds that we're going to be having over the next year and how we've structured the rounds going forward. And we've discussed this at the surgical executive with Dr. Feldman and the other divisional directors. So the first week, or the first Thursday of the month, will be still dedicated to surgical town halls with respect to COVID for as long as this might last. The second and third week, Thursdays of the month, will be dedicated toward divisional rounds. And then the fourth Thursday will be dedicated to ground rounds, which is what this is today. So these rounds are of a general nature. They're departmental wide, and therefore topics of interest to all of the divisions and to all of the members. So we're looking for speakers again, and we're looking for topics that have a general nature. And so they could be related to education, they could be related to research, they could be related to an interesting project that you're doing. There could be related to efficiencies in the operating room, these kinds of things. So if you have topics that you think would be of good interest for this larger group, then please send them my way. If not, I'll be kind of selecting people, asking people, cajoling people to give rounds. For this today, I just want to mention that we've given the time to the residents to describe to us their experience and participation in the COVID crisis. And as you know, they have been redeployed, many of them more than once, to COVID wards and into the ICU. And I think they've been a little bit the underdog in this crisis. We haven't heard from them. They certainly haven't been overtly complaining or concerned. They've taken what they see as a crisis and have dealt with it, I think, in a very professional manner. But I did want to give them an opportunity to try to express to us what it is that they did, and because I think a lot of us are not quite 100% clear what happened. And so this is their time. I've asked them to be very frank, very to the point and factual about what happened, and to give us an idea of some of the things that they may change if this would have to be done again. So I've given each one of them about 5 to 8 minutes to discuss their experience. And then afterwards, we'll have questions on the chat. So I'd like to try to get everybody through. We have 5 speakers. They're a little bit at random. Some of these residents I asked, some residents were put forward by their divisional chiefs and the program directors. So I'll just give you that as a foresight. And along with Paulo Fata, I just wanted to mention as well that we're going to be doing a larger survey of the surgical residents and their experience in COVID, so we can actually try to learn something. So with that being said, I'd like to get started, and we're doing it in an alphabetical order. So I'm just going to ask Saba if you're ready, and you can put your screen on and give us your experience.
Perfect. Hi, good morning, everyone. So my name's Saba Balvardi. I'm an R2 in general surgery, and I was deployed last week to the wards at the Jewish General. I was on K8. So before just starting to talk about my experience, I'll give you a quick summary of how it works. At the Jewish, up until last week, there were 5 floors with about 20 to 28 patients, and the team on each floor floor is compromised of one resident, one team leader who's usually a GIM staff or a RESP staff, and two other off-service staff. There's one resident who covers the night. I was deployed to be on the mornings. Overall, my experience was very positive. I guess it depends on if you're on nights, mornings, and how your team functions, but for us in general surgery, because of the reduced ORs, we are trying to have reduced exposure to patients, and we usually have one resident off 1 week out of the month to be able to cover in case anybody gets sick or to be ready for redeployment. So I was redeployed the week that I was off, so it didn't really affect my clinical exposure in surgery, and you're able to come back to work right after. So again, that wasn't a problem. I didn't have to stay home after. For when I was on the wards, as I said, it's a very, I felt like it was a very collegial, pleasant experience, because you have the team leader and you have two other staff, and they do the same work as I did regarding admissions, patient care, doing discharge summaries or CTMRPs. So everything was really nice. I felt like I enjoyed it because I got to learn a lot, especially being during the day. We rounded as an ICU style rounding. So I got to learn a lot about different things that you worry about at different stages of the COVID disease trajectory. And I felt like I was never bored because it was 5 days. I was learning new things every day. So I felt like if it had gone on for like 3 weeks, I might have been a bit more bored because it was like a completely different discipline. And I was on a ward where the youngest patient was 87. So a lot of it was social, like basically social work, a lot of talking to the family, level of care discussions, but still we had 2 interdisciplinary rounds that week, and the resident is responsible for running those rounds. So I felt like I was involved in their care. Other questions that I was asked to talk about was whether I would change anything. To be honest, I really enjoyed my experience. There was a lot of support. I remember whenever you're assigned to late shifts, and I had crying family members calling me, trying to get another appointment to see their family members, and you're kind of lost because you don't know all those logistics. But there are 2 staff who you have their personal numbers for these issues, and I was able to call them. They arranged everything. So I felt like the support was really nice, and there's a lot of teaching materials that we were sent, and I felt pretty prepared for the task that I was given and well supported. That's it.
Oh, thank you very much, Saba. We're going to get back to you because I have a few questions for you. So if you can just stay on, and then we'll get back to you. But I just wanted to give everybody a chance to kind of give their own experience as well. So is Araz there?
Yes, I'm here. Sorry, my video is just turning on.
Okay.
Hi. My name is Araz Kouyoumdjian. I'm an R1 in general surgery, and I was also redeployed at the Jewish General Hospital. I was redeployed almost 3 weeks ago now. And at that time, there were 6 COVID units at the Jewish. So there was also the PACU. That was a full COVID ward. But this has since been closed. In terms of how I felt it affected my surgical training, a little bit similar to Saba. Our schedules have been made that we have some weeks that we are off to reduce exposure, and I was redeployed during one of those weeks, so it did not affect my schedule of the month. It's more COVID in general that has affected surgical training, but not the actual redeployment process. In terms of how I was able to continue surgical learning during my time on COVID, they allowed me, when we had Zoom teachings and other academic activities, to attend those and not worry about, for example, being away for an hour or being on my computer for an hour. And they understood that I am also a surgical resident and I do have some learning objectives on that standpoint. And then, as Saba said, there was a lot of teaching given during ward time. So three times a week we had rounds, and we would go through patients, and then there would be a teaching about each patient. Twice a week there's also radiology rounds where we would go through imaging, not only chest x-rays, but CT scans and imaging that were done on all of the COVID patients on the wards admitted at the Jewish, and radiologists would go through these findings, and that was very, very educational. Every day, my staff also gave me an hour of teaching on the topic of my choice. I had a respirologist and a neurologist that were happy to give me some teaching that I found useful as well, which was quite great and something that I wouldn't have gotten otherwise. And then, as Saba said, we were given a lot of information before we even started, a Google Drive filled with documents to read and things to learn about COVID and how the wards were functioning. I was redeployed just once, and it was 5 days, and I was on days. The types of cases that were mostly on the ward, so they're mostly elderly patients coming from CHSLDs or residences. So there was a lot of palliative care and comfort care that we had to give to these patients. So it was a very difficult, but also different medicine than we're used to practicing as a surgeon. So I felt that it was, as I said, difficult, but also very educational and humbling. And I did learn a lot from that. There were some younger patients, but really not that many. It was mostly elderly patients. In terms of concerns during all of this crisis, I mean, I think they're my concerns are very, very similar to others, and they're mostly in regards to my family and others, but I think they're not very, very different. And then lastly, we were also asked to think about the positives through this. So I think I went through all of these points already. There was a lot of teaching. I felt that I learned a lot about COVID and was able to help, even if it's just to provide comfort and peace to these patients and their families, and to call them and assure them that they're being taken care of appropriately and in the most human manner possible. The team interaction during my week on was also fantastic. We would all share tasks. I was not just the resident who was supposed to do all of the work that the others didn't want to do. It was really shared, and it was quite nice. So I was felt to be an essential part, but not just there to do the parts that others didn't want to do. So that felt very nice and made my week go by quite quickly. I wouldn't have changed much, really. I think that the preparation before our week started, and then the continuous teaching during the week and shared tasks made it that it was very, I mean, if I had to be deployed a second time, I probably would have been, or will be.
All right, thank you very much, Araz. A couple of questions coming out from what you said, but we'll continue on. I think Ziyab is up next. Are you ready, Ziyab?
Hello. I've been trying to get my camera on, but I'm struggling with that. So if you don't mind, I'd like to speak without camera. Thank you, Dr. Lachapelle, Dr. Feldman, and everyone in the surgical faculty for giving us the opportunity to express our views today. And thank you to the other speakers for speaking so eloquently. My name is Ziyab Sarfaraz. I'm a third-year cardiac surgery resident. I am currently in my second redeployment block. I've done a total of 10 shifts so far over the last 2 redeployment blocks, with 3 more to go this weekend. In my experience, the rotations have been relatively quiet and calm. I did not get to see any new transfers from Cool C, but we did transfer a few patients to the ICU. The positives have been that I learned to work in a multi-specialty environment with doctors from different specialties working together to provide the best care during this crisis. One thing I found very interesting is that surgeons and doctors from non-surgical fields do not always have the same process of thinking. They both get to the same conclusion, but they both take different paths. One example I can remember is that we had a patient with metastatic prostate cancer who was admitted to the ICU with COVID pneumonia. He was eventually transferred to the floor and he'd been pulling out his Dabaf several times. Everyone was getting quite frustrated. I also had to put out a Dabaf on him while he had altered mental status and was coughing and sneezing while I was doing it. So one day we had a surgeon, a senior surgeon attending who rounded with us, and he suggested just suturing the Dabaf to his nasolabial crease. And the patient obviously didn't pull out his Dabaf after, and I believe he was discharged home. Another time we were struggling with patients who had hypernatremia. As many of you already know, that these patients develop pre-renal AKI quite quickly and they're quite hypernatremic when they're admitted. So one day we had a biochemistry staff or a fellow who showed up and rounded with us, and by the end of the shift everyone had normal sodiums. So it's good to work in a multi-specialty environment. Another positive from my COVID redeployment is that I got to catch up on my reading, I worked in my research, and I did make some progress in this regard. The negatives for me personally are not many. I'm in my third year of cardiac surgery residency, and this is more like a transition year to senior cardiac surgery when the responsibility of patients on the floor and the ICU increases. I was just beginning to get the grasp of the fundamentals of cardiac surgery when the pandemic started. And fortunately, we were still able to do emergency cases, but they were quite few. During this time when I thought that I needed to make the most of my last few weeks as a junior cardiac surgery resident, I got redeployed for my first time. This block, I moved to thoracic surgery, and just when I was beginning to get a grasp of things there, I got redeployed again. Fortunately, I still have another block to go, and I'm hoping the situation improves so that I'm not needed anymore. But of course, if need does arise, I wouldn't mind being redeployed again. My biggest concern during this crisis is obviously my family back home. I haven't told them that I've been redeployed because, to be honest, why worry them? Since the borders are closed, I missed my grandmother's funeral, which was last Friday, and my father is currently sick with Kouyoumdjian in Oman. I obviously would have liked to be there during this time, but because of the circumstances, I'm not able to. I am trying to stay positive though. Some of the things that I would change, I honestly do not think so many residents are needed to cover the units. I've discussed this with other non-surgical residents who were redeployed with me. They usually have different opinions. I think there's no need for a resident to be in-house after midnight in the COVID units. I mean, because if a patient does get sick, the COVID ICU fellow or the resident are in-house, and also the nursing is quite spectacular. The nurses, they know the algorithm for escalating O2 therapy, and most of the time the resident or the staff doesn't even need to be in the room to assess the patient because you get labs and a chest x-ray in no time. That way, less residents will be redeployed and more residents can be in their base specialty. If they say that residents are needed in-house for admissions or whatever, then I think that the shift should be 12 hours rather than 8-hour shifts that I've experienced. That way you'll need one less resident per day. I'd like to reiterate that these are just my personal opinions and definitely does not represent everyone's opinion at all. With that, I thank everyone. Thank you for your time.
Okay, thank you, Ziyab, and I'm sorry to hear about your personal issues.
Thank you.
And our sympathies to you. And again, thank you for doing what you're doing and trying to keep positive about it. So yeah. I'd like to ask Tyler if he's available.
Yeah, hi.
Hi, Tyler.
So hi, everybody. My name is Tyler Safran. I'm a second-year resident in plastic surgery. And I was fortunate enough to be the first off-service resident deployed. I came home from work on a Wednesday night and I was called and I was told that I had to going to work Thursday night. And I started doing at the Jewish, I was doing overnight shifts. I did 5 overnights. And it was quite stressful at the beginning, you know, coming into a field at the very, very beginning. So it was at the end of March, beginning of April. And and no one really knew what COVID really was at the time. No one had any real treatment plan. No one knew exactly what to do. So imagine me as a plastic surgery resident trying to take care of these patients overnight. It was relatively stressful at the time. But needless to say that the support system was absolutely fantastic. I was able to contact the staff on call. I was able to speak to the internal medicine residents that I was paired up with on another floor. And the ICU fellow, and the whole experience was overall quite positive, although very stressful. I'd also like to say, like, I have an amazing program director in Dr. Thibodeau. She was always texting me, always calling me to make sure that I was okay. It was a really nice feeling to know that there were people there to support me at all times. And I felt that the overall experience was quite positive, especially because I was at the forefront of what was going on and no one really knew at the time what to do. So it was very interesting kind of seeing the patients and having to examine each one of them and figure out what to do going forward. Another interesting point that I found throughout my rotation was finding new relationships with other specialties. So being able to call, you know, the cardiologist, and at the time they always thought that it was an internal medicine resident they were speaking to, but no, it's actually a plastics resident trying to figure out what's going on in the EKG, and at 2 a.m. trying to explain to them that they need their help. And sometimes it was a little bit tricky and trying to get them to help you out. But after a while, once you tell them you're from plastics, everyone runs to the bedside to make sure the patient's okay. So that was fine. And then after my rotation, the feedback that I got was great. And I was able to have a nice debrief with the whole team, and it was excellent. Unfortunately, when I finished my rotation, I found out that I had come down with COVID myself. Now, I didn't get it from the wards, and I'd like to say that that was, you know, just to prove how great the PPE at the time was, especially at the Jewish, and how all of the staff there were always very well protected. They had contact traced me before I was actually on the ward. My experience with COVID was quite favorable. I luckily had a very mild illness. It lasted for about 7 days, 8 days of symptoms. I did test positive for about 4 weeks, and it took 5 times for me to be negative, which was not a fun experience for all those who have had the test. And now on Saturday, I'm actually going to donate my plasma in hopes that that could help going forward. So overall, it was a fun experience, to say the least. It was stressful. For me, overnight, when a patient would not do well, I had to be there because, you know, I actually started the first night that my ward had opened. And so none of the nurses had even ever dealt with COVID patients before. It was a surgical unit that was transitioned. So that also was very interesting, trying to show people how to don on and off, and myself having not really been doing it super well. So we all learned together, and it was a nice experience and something that I will remember for the rest of my life and be able to tell people. So overall, quite positive.
All right, Tyler, thanks very much. And thanks for sharing that you actually tested positive. If you don't mind me asking you, you say you didn't get it from the wards. Do you know how you got it, or?
Yeah, so we knew, based on the contact tracing, we were able to figure out that it most likely happened prior to me starting in the emergency room at another hospital. And it was at a time where the actual emergency room wasn't fitted for COVID patients. So a COVID patient would come into the room, it would be cleaned, and then we would go into the same room to see another patient. And we probably got it from that, or a patient that was probably asymptomatic that we saw in the clinic. So it was really, I caught it at the end of March. So it was before all of the lockdown was in full effect. I mean, it was still there, but we were still seeing patients in the clinic, and we were still seeing a lot of consults in the emergency room. Also, as I see in the chat, how can I forget my amazing chief? Thank you for all your support as well, and Dr. Gilardino.
Just curious, I mean, when you were tested positive, how did that affect you in your family life, or and how did you maintain yourself at home?
Well, I'm lucky enough to live alone, so that was fine. It got really boring after 5 weeks of being at home. Luckily, I was introduced quite quickly into our e-curriculum that we have in plastic surgery, which has also been amazing. So I have Zoom lectures almost every single day. We started doing grand rounds, indication rounds. We have a journal club now. I was doing Zoom follow-ups. So that was fine from an educational standpoint. From a family standpoint, my parents still won't let me go home to see them. I still haven't seen my dog. I would drive to the West Island and pick up food off the driveway and then drive all the way back home, or they would do the same. But I basically stayed inside of my house for 5 weeks time. So that was a little bit difficult. And I won't say that I'm an anxious person, but let me tell you, having the diagnosis of COVID, especially at the end of March, beginning of April, it was quite stressful. You know, you'd read CNN about these young, healthy people not doing super well, and you obviously would be very afraid for yourself. But like I said, luckily I had it was just myalgias, fever. I had a little anosmia, and it was a little bit difficult to sometimes eat and taste my food, but that went away relatively quickly too. So that was okay.
All right, thanks, Taylor. We're always all glad that you're quite healthy now. Look quite healthy.
Thank you.
Yeah, and you're back in greens, which is a good sign.
Yes, I'm back at work full time.
All right, great. Okay, Sarah?
Yes, I'm here.
Is Sarah there? There you go.
Hi, everyone. My name is Sirajuddin. I'm a R5 cardiac surgery resident. I was redeployed early in March to the COVID ICU in RVH. It was early April. I was redeployed for 2 weeks at a time. I covered 8 shifts in 2 weeks. Each shift can have like 12 hours of a shift, morning and night. In the beginning, it was a little bit, I would call it a little bit disorganized, because the email that I got, I was first covered ICU in the MGH, and then on Sunday or Saturday or Sunday before I start, I got another email saying, no, I'm going to the RVH. And then on Monday, when we all show up, everyone was surprised by how many residents they have. So I think they probably asked for a little bit more residents than they needed at that time. However, they probably were expecting more patients because it was the beginning of COVID. So they expected a bigger wave of patients. At that time, we slowed down. I was a cardiac surgery chief resident, so I was covering the cardiac surgery ward. So I was redeployed from there, but we slowed down in doing operation at that time. We were only doing 1 or 2 cases a week. So I didn't really miss a lot of surgical experience from the COVID. In the ICU itself, in the first couple of days, it wasn't clear exactly what's our role as redeployed residents. So we actually spread in the regular teams, but then they decided to keep us in a different team. They called it teal, I believe, or some other color. But we were covering only morning and night as redeployed residents, and we were not seeing other ICU patients. The workload was not really bad. I was actually a little bit bored in my shifts because you don't really go to a patient. All of them are intubated. They're all lined up. If there's some lines to do, you will go and do them. I probably had 4 or 5 in my 2 weeks. But that's basically it. You round with the staff, you see the chart, you make the changes, the nurse will go inside and do the change, but not much for you as a resident to do, except of course writing notes. However, the staff will help you with that. And then the most exciting thing is extubating the patient. So we had few extubations, which was really exciting in the beginning. Some of them got reintubated, but you as a non-ICU resident or fellow, the fellow actually go and intubate, or someone who has a high experience. So you did not really get exposed to that. In my last day in the ICU shift, I had a little bit of sore throat. So I told people, and I a little bit freaked out. and I went to test myself, and I went home. I had sore throat for a couple of days, but my test came back negative. So I stayed home for a week just because our service was not really busy, so I didn't have to come back to the hospital. And then before coming back, my staff told me to go and test myself again because they were a little bit afraid that it's a false negative or something. So I got tested again, which was not a fun experience, but I was negative, thankfully, and I did not really have symptoms. So that basically was my experience. If we have to change something, I think probably it's just because my redeployment was at the beginning, so everything was a little bit disorganized, but I think they got better a little bit more. And probably decrease the coverage from the resident would be nice, because even at night, we were 3 residents covering 3 teams with a fellow and a staff. So it was a little bit too many people, and we were not doing much. I probably just saw a consult overnight one day, and we were not doing much other than answering the phone and tell them to increase metoprolol or decrease it, or increase sedation, decrease sedation. So it wasn't much of a work overnight. I don't know if something changed probably after when they got more cases. That's basically it.
Thank you, Sarah. I have to say that the staff person that you're talking about is me, of course, right?
Yes.
And I guess we had a discussion about your symptoms and so on and so forth. And at that time, we were just starting to ramp up again. And, we had read that there were these false negatives and so on and so forth. And I think at that time, it wasn't quite clear what the parameters should be. So I certainly take the responsibility for that. But we certainly didn't want to wipe out the operating room that we had on the basis that there might be somebody positive. So anyway, we're all learning a bit, and that's really what this was about, and trying to provide an experience. I think for me anyway, I hadn't heard a lot of these stories, so it was quite inspiring actually. And some of the themes that I'm getting is that as residents, all of you kind of just accepted what it was and tried to make the best of it, see the very positive aspects of this redeployment. And that came out pretty clear. It also came out pretty clear that maybe there's not as many people required, but I'm just trying to get a sense, maybe, and I'll start with you, Sarah, as well. People start maybe thinking of questions on the chat. How has this affected you as a chief resident? Because there is a period of 2 months there where you've been kind of blocked from operating. I mean, so
yes,
just to see what your thoughts are on that.
I mean, yes, these 2 months, it was supposed to be the month that I operate most, because the R6 are going for the exam, and I'll be covering the service. I don't think the redeployment actually caused the problem. It's the COVID itself, where we slowed down and we didn't really have much of cases. So yes, I lost these 2 months, and but fortunately, I still have another year to cover for. So I'm not that worried about, but something would probably were going to be different if COVID did not happen. I probably would be in a different level, or operate differently, or progress more. But now we just have to deal with what we have.
Right. Just deal with the problem. That's great. Just kind of maybe getting a little bit more perspective. Heard a lot of great things about the experience, but let's say we're going forward now, and this has to come again, and there are certain issues. I'm just trying to get the feel from the group what differences that you might want to employ going forward. Maybe Sarah or Tyler, maybe you could.
You mean different in the redeployment?
Yeah, I mean, like going forward, I think everyone realizes that they've had a fairly good experience or their positive experience, although it's not a surgical experience, obviously. But going forward now, if it were to happen again, because that's the other issue that we're trying to grapple with, how would you see that?
I mean, if we have to do it again, I think we have to do it again. We as surgical residents, we're missing surgeries because, you know, all the operation is closed and we are basically staying home, either studying or doing some puzzles. So it doesn't really affect, it's the COVID itself that is affect our, as I said, our training. If they need us to be redeployed, we'll do it. Do they have that many do they need all that residents? Maybe not. Maybe we'll think about decreasing the number of residents, even the staff, because as I heard, even at the Jewish, they have 4 staff per team, 3 staff per team. I don't know if that's actually needed with all that exposure. So I think that's a thing that we have to think about, but if it happened again, probably we will be needed and we will do it again.
I think when it comes to just for redeployment, I think what was interesting was, at least when I was there, because I was alone, they really gave me very, very clear guidelines as to what I was supposed to do and what I was not supposed to do in terms of my goals for the overall night. And I think that going forward, it seems, at least from everyone, I didn't see this experience myself, but if there's a lot of residents, at least, you know, when the residents are on, they have clear guidelines as to what they need to do. Like, you're in charge of the admissions for the day, and like it's an 8-hour shift and this is what you do, as opposed to just, I think it would be a shame if we were redeployed and we were losing clinical experience in our specialty to go sit around and be just an extra member of the team. And of course our help, you know, if we're needed, I think we're all residents, I can speak for all of us, that we would just jump on any opportunity where our chiefs and program directors say, you know, you're required to come help. But I think it's important to feel like we're doing something that adds to the team, as opposed to just kind of being there as a named place.
Okay. Any of the others, Araz, Saba, or Ziyab, do you have any thoughts?
No, I completely agree with Tyler and Sarah. I mean, we are doing what's needed. If need be, if need arises, we're definitely going to redo it again. We're going to get redeployed, do our part. If, as Sarah mentioned, it was pretty haphazard in the beginning. I had that experience as well. But in my second redeployment, it's a bit more, the tasks are more clear. Everyone knows what they need to do. Most of the time, yes, it is social work, speaking to the family, finding this position, but it is what it is, and we will do what's needed to be done.
All right, thank you. I don't know if Saba or Araz have any other comments.
Yeah, I completely agree. I think also what I felt was, as surgical residents, the amount of work that we were expecting to do per day was way more. So like, I think definitely like number of residents per team can decrease. It will add on to other members of the team, which for us was like a pretty normal work day, like 6 to 6, it could have been done. But I don't know if it would have been sustainable for people who were doing it for longer, at least for like, because we were there for 5 days. But I agree, and I see in the chat that apparently they're trying to move to 1 full period out of the year, redeploying residents. For me, I think it would not be as well received, just because I think for a full month being taken out of your specialty, I think it affects you way more, because you're away from the OR, and also being in another specialty, you're not challenged, I think, as much. Whereas doing it 1 week out of a month, it's kind of like a break. You get to read, you get to kind of be fresh and excited for the OR, and you get to go back. So I mean, if we ever had a choice, I think the way we're doing it now is nicer, but I don't know. I guess it's not my decision, but that was my opinion.
Yeah, nice comment. Thank you. And I think we haven't heard from Araz. Yeah, I think.
I agree with all that was said before, especially for them if we have a choice. I mean, the 1 week per month worked extremely well. It might mean more organizational efforts on the side of the people having to make the schedules, but all in all, I mean, it was a good exposure, a little bit less work than I'm used to, but still got a lot of teaching and learned a lot from the staff and the colleagues that we don't necessarily work with as much because, well, we're surgical residents, and so they taught us different ways of going about the problems, and it was a good exposure.
That's great. I just want to read to you, I mean, some on the chat, there have been a couple of people, both Mohammed from urology and Senator Lieberman have informed us as well. And we just learned about this yesterday that PGME wants the residents to perform 1 block out of 13 in redeployment until this COVID is over. This is something that's kind of fallen from a little bit from the sky without too much discussion. So we're certainly going to be digesting that and looking at it, and clearly some of your suggestions are important. And I would also agree that being taken away for a month at a time is somewhat long, especially if you're, for example, like in Sarah's position as a chief resident. These months are really, really important. So we're certainly going to be looking at that. I just wanted to read some things from the chat from Kozar. Thank you to all the surgical residents for everything you had to go through and over these past few months. So that's Kozar. From Ciro Andonian, thank you to all the residents. And then from Dr. Feldman, our director and chief of the department, amazing and inspiring stories. Appreciate all that you've done. And thank you also to the PDs for adapting to online learning and making sure we keep teaching. I think that's also quite, obviously quite important. And I think from my reading and what you were saying and from speaking to some of the PDs and other residents, it sounds like you may have been getting more kind of formal teaching in these months than we normally do. And of course, Dr. Feldman recognizes, as we all do, that surgery residents are really used to working much harder. And so maybe that's where all the boredom comes in. Another one from Richard Margulies, senior surgeon from the Jewish. It strikes me that young people come for training and we're supposed to be experienced and wise people to guide them through. Now comes something none of us have ever seen in our lifetime, and we are learning from the residents, which I think is quite important. Kudos to them for stepping in and assuming what they probably do not yet realize is a leadership role. I think that's that's a very good comment, and I think quite right. I think from what I'm hearing is trying to deal with the problem at hand and doing what needs to be done, and doing it in a very professional manner. And so I think if you want to look at the CanMed's roles and professionalism and scholar, I think you guys have ticked all of those boxes quite well. So I, again, like to congratulate you and thank you for the things that you do. And certainly, you know, offline, speak to your program directors. I mean, if there are other issues that you need to express, please do them, bring them to us, and we will make sure that your experiences are relayed, and also what we feel is also in your best interest for your training. And that's what we're trying to look at going forward. We realize that you know, you're willing to do this, and we appreciate it very much, but we also want to protect your education and your surgical training. So one from Dr. Freed, previous department chair. The maturity and professionalism of the residents is making I guess I meant amazing. Yeah, there you go. Amazing. Thank you. So it looks like few questions, most are very positive comments. And so I don't think there's anything else I can add to what was already been said. I think the chat room seems to be relatively quiet. And so it's 8:15. If anybody has anything else that they would like to say, now is the kind of the time to say it. If not, I think we're going to let everybody maybe get back to the OR perhaps for 8:30, which would be a good thing for all of us, I think. So again, I'd like to thank you, residents. I'd like to make a special thank you to Saba, Araz, Ziyab, Tyler, and Sarah for taking the time and willing to give their personal experiences and relate some of the personal things that that have happened to them during this period. And again, we'll see you on the wards. Okay, thank you very much, everyone.
Kevin?
Yes?
I'd like to firstly congratulate all these residents on their amazing stories, because this sort of really brings the art to medicine as opposed to the science, which we're usually involved in. But I'd like them all to make notes and keep their notes and enhance them, because this is going to become an important part of the new square knot that's coming out, because a lot of the things that normally fill the square knot, like Fraser Gerd Day, Lloyd McLean Day, and all the other visiting professorships are not going to be around. And so this is going to be really the focus of the next square knot. So I'd like to thank them all for their excellent presentations.
All right, well, thank you, Dr. Sigman, and thank you, everyone. Please write these comments down and these thoughts, and we'll actually get them published as a COVID special. So again, thank you very much, and we'll see you next, well, we'll probably see each other next week, but we're having rounds on the 25th of June, and Mylène Arsenault from the Family Medicine is going to give us a talk on how to use Zoom or telehealth and teleconference when we're doing telemedicine, and also how we can make sure that we're aligned with the requirements from the Collège des Médecins du Québec. So I think that'll be an interesting one for all of us, since we're doing all of these Zooms and meeting patients virtually. Okay, guys, thank you very much, and we'll see you in June.